Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session.
Well, a little bit of a change of plans. This is Charles Hawley. I'm the Director of Projects with NAUTO. I'm going to introduce this session really quickly and turn it over to the moderator. So thank you all for joining us for the conference. This is the bittersweet session of the closing plenary. We have a panel that'll be discussing addressing health inequities and improving patient care through partner collaboration and data analytics. The sponsor of this session is the Human Services Research Institute, or HSRI, and we really appreciate their support. Let me go ahead and introduce the moderator for this session, Jeff Stoddard with BerryDunn.
All right. Thank you, Charles. Good afternoon, and thank you for attending this final plenary session. It's been a great conference. I hope everyone agrees with that. My name is Jeff Stoddard, and I am the co-leader of the Data Management and Strategies practice within BerryDunn's Health Analytics Group. We work with state governments and not-for-profit organizations to provide data management, analytics, health policy, and actuarial services. We're pleased to be a NAUTO featured partner and a part of this conference. Today we have three panelists representing different but complementary perspectives who will discuss initiatives supporting the reduction of health inequities in the state of Maine. The topic of health disparities is not new and has recently come to the forefront because of the inequities we're seeing related to the COVID-19 pandemic. There have also been several sessions on this topic during this NAUTO conference, and all of which the ones I've seen have been great. So hopefully we can tag along onto that. During this session, please feel free to ask questions using the chat feature, and we'll address them at the end of the panel discussion. All right, let's bring in our panelists and I will introduce them. All right, hi everyone, welcome. Chad MacLeod is the Director of Product and Communication at HealthInfoNet, Maine's statewide health information exchange. In his role, Chad works with a team of project managers, clinical educators, data analysts, and software developers to deliver high-quality services and materials to the HIE's customers, partners, and end-user communities. His primary interests include ACO and payer-focused analytics and reporting, organization provider directory management, and applications of social health information. Thanks for joining, Chad. Next up, we have David Jorgensen, who is the Director of Data Analytics for MaineCare, which is Maine's Medicaid agency. His work is focused on using data to improve health outcomes and health equity within the state of Maine. David actively seeks out collaborative and multidisciplinary initiatives that hope to bridge the gaps between healthcare providers, policymakers, and analysts. His person-focused approach to analytics has helped MaineCare to recognize and act on disparities identified during the COVID-19 pandemic. Hi, David. And Leanne Kandura is the Director of HSRI's Population Health Team, and she oversees HSRI's services aimed at improving the quality, availability, and use of population health data for states, providers, policymakers, researchers, and consumers. She has worked with the Maine Health Data Organization, or MHDO, for almost a decade, overseeing the development and implementation of the data collection and reporting systems for their APCD, hospital encounter, quality, and financial data systems. Leanne has deep experience with vetting and remediating data quality issues, developing data standards, and uncovering opportunities for system streamlining and efficiencies, including supporting other Maine state agencies, policymakers, and consumers accessing and utilizing MHDO's data. So now we're going to go ahead and start our panel. Again, if you have questions, please put them in the chat and we'll get to them towards the end. The first question is for David. David, why is addressing health inequities generally important?
Hi, Jeff. That is a great question. If you were listening earlier today, you probably heard Joel Cohen from AHRQ say that 85% of a person's health is determined by their social conditions. I think that that same idea has been communicated through other research as well. There's a small minority of our health that is actually tied to the care that's provided within the four walls of a medical setting. This graphic here shows a similar story to that. That leaves that 80 to 85% of a person's health outcomes that are determined by other factors. And those factors go beyond even what's listed here. So, you know, a person's race, ethnicity, their primary language all play into the type of health outcomes that they are likely to see over the course of their lifetime. And the zip code that they live in also has a large impact on the health outcomes that they expect to see. So if we want to improve health outcomes, then we can't just focus on what happens in medical settings. We need to look at ways to address these health inequities, these social determinants of health, and find a way to get people to maximize their health care and have opportunities to maximize their health care. I want to say from a Medicaid perspective, Medicaid organizations are uniquely positioned to work on health equity issues because of the populations that we serve, and we really have a direct imperative to provide those safety net services for the members that we serve, and to be good stewards of state resources. If disparities are left unaddressed, we know that it puts a large burden on the healthcare system and ends up being very costly down the road as we attempt to treat things through the medical system rather than addressing the disparities early on.
That's great. Thanks, David. All right, this next question, we're going to start with you, Chad. So Chad, again, is from the HIE, HealthInfoNet here in Maine. So he works with a lot of clinical data. Chad, what type of social health data collection efforts are happening in your realm in Maine? And what has and hasn't worked historically, and why?
Yeah, good question. So with HealthInfoNet and the statewide HIE, I think what we do really well and what our mission is to capture that 20% of the clinical determinants impacting a person's health that David mentioned. But the 80% is something that we're continuing to work on at HealthInfoNet and generally just across the state. And there are 3 projects that I want to speak to that's happening in Maine that may be relevant and resonate with audience members. So the first is HealthInfoNet has partnered with an organization called the Maine Council on Aging, which really promotes the thriving of older adults as they age through increased programs and partnerships. And this first one is we worked with the city of South Portland, a a specific municipality to determine how could we bring together stakeholders, whether that's payers or community-based organizations or healthcare organizations to the table to collect data available on South Portland's older adult residents to drive municipal level data decision making. We did that over the course of 18 months. And as a result of that data dashboard, we identified that South Portland older adult residents really have a problem with falls and fall-related incidents and injuries. EMS data shows that 24% of all calls in the state, within the city rather, are reported about falls or fall-related incidents, and 60% of those are for adults that are older than 60 years old. And so 3 outcomes happened from this program. The first is that we worked with Maine EMS to put in place a point-of-care referral system so that when a Maine EMS person comes to the scene and assesses a person for fall-related injury, they can make a referral to another entity to give that person the necessary resources available to them to hopefully mitigate that risk the next time. They also HealthInfoNet receives Maine EMS data on a real-time basis. And what we were able to do with our event-based notifications was to alert primary care providers every time that one of their patients has a Maine EMS run report generated in the system that's specifically about a fall-related incident. And then the third bit was that we put a grassroots program in place using South Portland's age-friendly community to actually raise awareness and education about falls prevention and intervention in their community. The second project was, it comes from CMS, it goes down to MaineCare, so David could speak to this in more detail if there are questions, but it's about long-term care data sharing requirements to increase care management across those long-term care facilities in the state. At the crux of it was the decision for HealthInfoNet to connect the remaining long-term care facilities in the state to the electronic health record system. That was a total of about 100 independent and small long-term care facilities. But the piece around the community and the social side was that we also, for the first time, connected the service coordination agencies in the state, as well as a couple of the area agencies on aging. And those programs are designed specifically to help members in the community find the necessary resources, the social services, the community-based resources that they need outside of the clinical setting. And if we gave them access to the clinical data as well, they could do more informed decision-making. And the last one is HealthInfoNet worked with the Maine Primary Care Association to assess the screening efforts done by federally qualified health centers in the state using tools like Prepare or the CMS social risk screening assessment tools. And what we learned was that the FQHCs in the state all have different ways of collecting the data, using different tools, measuring different outcomes, and then operationalizing that data by sending it to the exchange in different ways. And so as a result of that convening effort, HealthInfoNet devised a data standard for the FQHCs, which draws heavily on the Gravity Project social health data mappings, which then flow to the United States Core Data for Interoperability standard to make it such that social health data is collected through those screening assessments in a standardized, consistent manner. So those 3 projects acting independently and what could seem in silos are all being brought together now in a statewide effort to build what's called a community health information exchange. So it's bridging the community and the clinical settings to tell a more comprehensive story of a patient's journey through healthcare and community areas. And so this is really in the infant stages in Maine at this point, trying to figure out what does the data governance look like, what does the technical infrastructure look like, and bringing together the stakeholders who have some say in the matter.
Yeah, that's really interesting. You know, before kind of prepping for this, I had never heard of a community health information exchange. It's really interesting stuff. As a South Portland resident myself, I'm hoping I'm not in your agency on aging data quite yet. All right, we'll go over to you, Leanne. Same question: what type of social health data collection efforts are happening in your world, and you know what's working well, and what could use some improvement?
Great. Thank you, Jeff, and thank you to my other fellow panelists and Mainers. The specific examples that Chad just shared provide a great overview of the important efforts already underway in Maine. I have had the privilege of working with the Maine Health Data Organization for a while now. It's the state agencies whose purpose is to create and maintain a useful, objective, reliable, and comprehensive health information database that is used to provide to improve the health of Maine citizens. And as David mentioned earlier, traditional health data only tells a portion of the patient and population health story. And so in order for the MHGO to be a truly comprehensive health information data set, there's been some historical gaps in the inclusion of social health data. I'm going to do a quick review of some of the key data assets and the status of information to help understand social determinants of health in Maine. The most comprehensive data set at MHGO is the Maine hospital encounter data, which contains every encounter that happens in a health system, hospital, or any affiliated practice, representing every ER and inpatient visits and upwards of 80% of visits happening in all doctor's offices across the state. We have detailed information on the individuals accessing care, such as their geographic location, age, gender, race, and ethnicity. Race and ethnicity information has been collected in a standard comprehensive way within this data set for well over a decade, and it is populated a vast majority of the time. MHGO also houses Maine's APCD, and while we have some information about individual members, race and ethnicity information has only recently become a required field for submission from the payers. And I think really the MaineCare agency is the one that we have the most information from, coming from Medicaid in that data set. We are working on a combined patient ID, so even though the APCD information is sparsely populated, we do think we can link to a more robust information that's found in the hospital encounter data set. I do want to take a minute to also talk about some key legislation that will support social health data collection in the future. In 2019, recognizing the state's need to prioritize racial justice, the Maine legislature created the Permanent Commission on the Status of Racial, Indigenous, and Maine tribal populations. And the 12-member commission was charged with studying the status of historically disadvantaged populations, conducting public hearings and outreach to learn more about the challenges and needs of Maine's racial and ethnic minorities and tribes, and to make recommendations to the governor and legislature to advance racial justice. One of the recommendations from this report called for the allocation of resources to address health disparities. For proposed and future legislation, it's important to ensure accurate data collection for the diverse racial and ethnic background of Maine citizens, and it is difficult to assess the healthcare environment and success of related legislation for those diverse populations without having this key piece of information. The best method to meet this goal is to have standardized practices within the healthcare system surrounding the collection of self-reported race and ethnicity data. And to that end, HSRI is now working with MHGO on LD 274, Public Law Chapter 34, directing MHGO to determine the best methods and definitions to use in collecting data to better understand racial and ethnic disparities in the provision of healthcare in Maine. And we're working on a report by January 1st, 2020. The MHGO will submit the report, which should include suggested legislation based on this evaluation, to the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. So with the overarching goal to use data to guide policy, and with the two-pronged approach to reduce disparities while improving health access and outcomes, we are engaged in these efforts to ensure that missing, incomplete, or poor data quality are not the reasons that we can't address social determinants in Maine. So I guess that's my long-winded response to that question.
Yeah, that's great. It'll be really interesting to see and hear about the findings of your report and how that standardization comes together. There's been several sessions on standardization, and it's certainly a common theme within this group. All right, David, on to you. What type of social health data is going on in MaineCare?
Yeah, so I'll first address what kind of the current state is. We, in some ways, have very rich data that just comes through the administrative enrollment data. We do collect information about race, ethnicity, primary language, birthdays, things like that during the enrollment process. There is also other state programs, department programs that we have data collected on, like if a member also applies for SNAP benefits or TANF or WIC. So there is a lot of potential richness in what types of administrative data we could use. The limitations we've really hit are data silos and not being able to share that data super well across the department. Some applications for certain programs also collect the data in a different way. So the race information collected on a MaineCare application might not match up with the race information collected by another program. So that goes back to that standardization point. I will say that even though our race data is relatively well populated, if it's not used, the data quality kind of gets ignored. And so we've found, because it was not really being used in a lot of reporting for a long time, there were some data quality issues with that race data and how it ended up being used in some reporting. I've tried to make a point of just incorporating that information in regular reporting, and we have found ways to address those data quality issues. So I think that's an important piece. It doesn't necessarily improve data collection, but it maintains higher quality standards for that data if it's visible in the reporting that we're using. Looking forward to a future state, the state has just created the Office of Population Health Equity that is within DHHS. It's officially run by Maine CDC, but it will be partnering with other DHHS offices like MaineCare to address initiatives that improve data collection on social determinants of health, improve data collection efforts on race, ethnicity, primary language, even gender, offering a non-binary option on all of our applications, and incorporating better data governance so that we don't have to worry as much about the data silos and always get stuck in red tape discussions of what information is going to be shareable or not shareable, and kind of having to reboot those discussions from scratch every time data sharing comes up.
That's great. So David, do you have a sense of how well Z codes are being used related to social determinants of health within the Medicaid claims data?
Yeah, so we've taken some look at Z codes. They're unfortunately not used in a super regular, reliable way. There are, we can glean some information. I think there's a homelessness or housing instability code, set of codes that are somewhat regularly populated by providers, but they're usually only populated by providers who are providing housing support services. So it may only really be useful to flag members who are already receiving the service, and might not be a reliable way of flagging members who maybe should be receiving the services. And there are plenty of other Z codes that could convey some valuable information and just really aren't being populated at all, being built at all. So they end up not being super usable in terms of really identifying the members who have those particular social determinants.
Great, thanks, David. And Chad, do you, as far as the health information exchange goes, what are you guys seeing as far as Z codes are concerned?
Yeah, so not a whole lot of population. I think what we find is that if it's not on the primary, secondary, or tertiary slots in the diagnosis on the encounter record, the providers aren't seeing the data or they're not using it. They don't look beyond that typically within our charts. And so that's where the use of a social risk screening assessment tool, like a Prepare, like the CMS tool, and so on and so forth, those are collected in a separate stream beyond the encounter record in the HIE. So we're actually able to get the whole gamut of social health data that are collected on those tools if they're sent discretely and separately from the providers. And as I mentioned earlier, the Maine Primary Care Association and the federally qualified health center work that we did, that was an effort to make it more consistent, make it more voluminous in what we are receiving so that we can present that back to the providers in a more comprehensive fashion. But right now, on the encounter records alone, Z codes are few and far between from what we're seeing being sent to us.
Thanks, Chad. All right, moving on to our next question here. In what ways is the social determinants of health data being applied in analytics and reporting? And we're going to start with you, Leanne.
Great, thanks, Jeff. So in order to answer this question, I first want to provide an overview of the framework in which MHDO is able to make data available for analysis and reporting. The use, release, and reporting of data by MHDO is governed by Rule Chapter 120, Release of Data to the Public. The purpose of this rule is to specify the permissible use cases, of which there are 3 levels, level 1, 2, and 3. Level 1 approximates to de-identified data. Level 2 contains some individual characteristics but has replacement identifiers so individuals remain anonymous. And level 3 contains direct patient identifiers and has a very limited set of allowable uses. Chapter 120 also describes processes for requesting the release of data, and to which level 3 data is highly restricted. So historically, race and ethnicity information under Chapter 120 was limited to a level 3 data release, which pretty much meant that any entity outside of Maine's CDC was not permitted to receive these data, which also meant that no analysis being done by the MHDO or its data recipients could disaggregate data by race or ethnicity. And in order to address this issue, MHDO is proposing a rule change to allow race and ethnicity to be accessed as a level 2 data element, which would make it more widely available, such as zip code level data, but would still be covered under a DUA to protect small cell sizes. So while statewide Maine may rank last as it comes to diversity, we certainly have some very diverse communities in which we have no information available to understand the structural racism that could be impacting their access to healthcare or health outcomes. And we're doing these communities a disservice by claiming Maine is too white to try to make this information available in ways that could benefit them. And I'll quote the Associated Press in their headline about the results of the 2020 census. Maine becomes more diverse, but still whitest state in the nation. So in addition, knowing that we have the lack of information available to report, we've been working to geocode all of the individual data across MHDO's data assets in order to bring community level characteristics. And, similar to what Chad was discussing, we want to better understand the communities in which people live. And as we know, racism and socioeconomic disparities are the primary drivers in health equity, and geocoding significantly enhances our ability to incorporate social determinants of health into our existing and future analysis. And we'd also love to, explore ways to get other information, not only to be able to link to data sets such as the American Community Survey, but to also understand the assets that the HIE has within our state. And so we really look at the opportunities that this creates for more specific and targeted healthcare analyses, and especially in areas where there can be significant variation. So finally, in future reporting, we are committed to standard breakouts to acknowledge the impact of social determinants. I think David touched on this earlier too, that this will be a standard part of how we report these data in the future. It will always be presented by demographic factors, and we look forward to working across state agencies, including the Maine Medicaid office, and with stakeholder groups as part of the LD 274 efforts to understand how the communities most impacted by health inequities need and want these data reported. We want to hear from them what measures and metrics are important. And that will be the main driver in how we report and disaggregate this information going forward. So we really look forward to bringing those stakeholders together over the next few months.
Great, thanks, Leanne. And Chad, within your realm, can you speak a little bit about how the types of analytics and reporting that HealthInfoNet is doing with social determinants of health?
Yeah, definitely. So I think before I get into it, it's important to kind of say what are the types of services that an HIE provides, right? Our mission really is to improve patient safety, quality, delivery through what we call our clinical portal, which is our statewide electronic health record system. That was what we started with, and that's our bread and butter. Really, it's akin to an Epic or a Cerner or NextGen. It's connecting the systems that don't traditionally talk to one another to make it so that a provider can see all of that data, regardless of what proprietary system they're working in within their confines of their four walls. And so, starting with that clinical portal, we receive real-time HL7, CCD, CCDA data, but we also receive Medicaid claims from MaineCare. We also receive some other extraneous and miscellaneous data sources that we combine and integrate within one package. And as social health data is entering our world, we make that available in the clinical portal so that providers can have the most comprehensive information available at the point of care. We also have analytics and reporting, and it starts with our predictive risk modeling. So we have a daily update of predictive risk models. We have 22 different models that span conditions, through events, through utilization, projecting out their prospective 12-month risk for various activities in the healthcare system. And what's really interesting about these is that because historically the HIE hasn't had a whole lot of social health information or community information, those risk models are driving specifically on the clinical data that's coming through our system, which makes them accurate from a medical lens, but we're missing some of the other factors that drive those clinical events, like are they homeless? Do they not have food one day? Are they having trouble getting to their healthcare provider? And specifically around admissions to the inpatient or the emergency department over the next 12 months, or readmissions to those two settings within the next 30 days. Those are 4 different risk models that we calculate. And there are what are known as risk drivers, which are different events that kind of tip the odds of having a different risk for those different activities. And within those, community information and social information is so important. And you can see that somebody who is homeless or somebody that is food insecure becomes so much more at risk for having a utilization-based event in the next 30 days, 12 months than those that don't. And so the more that we're able to collect that information from our providers, the better we're able to make those predictive risk models more consistent, more accurate, more reliable to help our providers and MaineCare use the tools more effectively. This is all kind of coming to a head, and maybe I can hand this one off to David nicely, is that HealthInfoNet works with the state of Maine's Medicaid agency, MaineCare, in what we call our MaineCare Analytics Platform, or MAP for short. And what this does is it's a Tableau-based reporting dashboard tool which splits up our analytics into 3 buckets. I forgot to mention that this takes in the same clinical data. We have a real daily eligibility file that's sent from MaineCare that we can only show eligible members' data for. We also get the medical and pharmacy claims on a monthly basis, and we combine and integrate that data with our clinical information to tell a kind of comprehensive story about the Medicaid members' activities within the healthcare system. So back to those buckets. Descriptive analytics are saying the counts and the rates of inpatient or emergency department encounters over the last 365 days. We have those predictive risk analytics, so looking at the 22 risk models, whether it's your risk for COPD or your risk for developing asthma or your risk for getting readmitted back to the emergency department. And then the third bucket is performance measurement. So we calculate ECQM measures for MaineCare in alignment with their value-based purchasing arrangements with their accountable communities, as well as with their primary care 2.0 initiatives. And we use that based on our clinical data. One important caveat to make is we don't blend the claims data into that ECQM process. It's driven strictly off from the clinical data in real time. So that's the value add that the HIE provides to MaineCare from this performance quality measurement perspective. And so we take those three buckets, we put them into Tableau-based reporting, and we give those back to MaineCare, which David could speak to their uses of it. But in terms of social information and community information, the more we get about that, the more we can cross-cut and stratify those analyses to make them even more stronger, even more interesting. And so you could look at, for example, the predicted risk of getting returned to the emergency department for members who are homeless or members who are food insecure. And so really bringing in the data that we can capture from the social risk screening tools to make those various clinical-based encounters traditionally more accurate to what's actually happening at the person level.
That's great. Thanks, Chad. Yeah, David, we'd love to hear a little bit more on MAP from you.
Yeah, absolutely. I first off want to say that this the collaboration on the MAP tool has been really great. This tool has been used for a while by MaineCare's ED collaborative. They're focused on identifying members who are high frequency utilizers of emergency department services. That was the primary use case of that tool for a very long time. With these additional features that Chad has mentioned, they've kind of gained the ability to identify first like populations of interest, looking for specific vulnerable populations at an aggregate level, and then drilling down within those populations to identify individual members who meet the conditions of the filters they've used. One other great feature that we've been able to incorporate into that platform is MaineCare has the ability now to share member rosters with HealthInfoNet. So if we have a population of interest that we're concerned about, we can share that with HealthInfoNet, and they'll add a filter flag for us so that we can easily subset the data to that population of interest. So even if it's not something that HealthInfoNet has through their clinical data, if we identify a population through our programmatic administrative data or through our claims data, we can create that roster and share that to create that filter. That's been especially useful to us because there is no real claims lag. If we're trying to use just our claims data, even with emergency department visits, it can take quite a while to get real accurate information on true ED utilization. So at that point, if you've waited weeks or months to see who the high utilizers are of ED visits, it gets really difficult to coordinate care for those members. But if you get a daily refresh and the data is near real time, then that care coordination team can be very actively engaged in seeing what happens on a day-to-day basis and really be in direct contact with the members who need it most. I also want to talk about, I mentioned earlier, just incorporating demographic features as a standard practice in our reports that we create. I've asked my team to whenever we need to report cost or utilization measures at a population level, that we do provide those breakouts by race, by age bands, by gender, by geography. A lot of the disparities that we see, depending on the services, could be tied to any one of those conditions. It's not necessarily always driven by race. Sometimes it's driven by being in a very rural area. It might not be driven by proximity to a hospital, but it could be driven by other factors. So having those breakouts just allows us to see where there are those disparities, where there are correlations, where there aren't. And as a result of that, my team has been asked repeatedly by other offices in DHHS to be able to provide that information about COVID vaccination status for the member populations that they serve. So we were recently asked to provide a report on vaccination status for kids in foster care, and we were able to develop that report with our standard reporting on demographics. We provide regular updates to our Office of Aging and Disability Services on vaccination status for the members that they serve, whether it's residents of long-term care facilities or members receiving other services administered by that office. So that's been a huge value add. Sometimes there are disparities, sometimes there aren't. Sometimes it's hard to tell because the populations are small and we can't necessarily determine if there's a true disparity there or not, but it is useful information to have, and just being aware, having that awareness that there could be different communities that you're serving is important. One other important thing I wanted to call out is with Medicaid expansion, it was very important for us to collaborate with MHDO to kind of understand what portion of that expansion population was coming from another insurer, or if they were uninsured. So they were able to provide us with a great report that showed us about 28% of MaineCare expansion members had no insurance records, no enrollment records within 5 years prior to our MaineCare expansion. So without that collaboration with the APCD, we would only know that about 50% of expansion members were previously enrolled in Medicaid, but we would have no information about whether they were ever insured by other insurers, if they'd been a long time uninsured. So that was really good information for us to have that really wouldn't have been possible without that collaboration.
That's great. Thanks, David. So we've talked about, you know, what data is being collected within your various organizations. We've talked about the analytics and reporting that's being done with social determinants of health data. Now we're going to pivot to, have you seen specific examples where these efforts have made a difference in patient care specifically? So we're going to go back to you, Chad.
Cool. Yeah, just interest of time, I'll use one example building on what Leanne and David have spoken to so far on race and ethnicity data. So, and I see a question about this in the chat as well, so hopefully this touches on that. So back in April of 2020, when COVID was hitting us hard in Maine and elsewhere. HealthInfoNet connected to the state of Maine's Health and Environmental Testing Laboratory. We call it HEDL. That's the state's laboratory where they collect and process all of the COVID-19 laboratory test results. And that gave us a really comprehensive picture of the cases, the distribution, the prevalence. And we packaged, again, that up into some analytics and reporting, and we provided it to the Maine CDC. And what they came back to us very quickly about was, well, this is great, but can you cross-cut and stratify all of these analyses with any race and ethnicity data? And so we went back to the well, and we looked at what race and ethnicity data we have in our system coming from the EHRs. And surprisingly, it was actually pretty darn complete. But the interesting part was that it was also pretty darn messy. We get a free text field of race and ethnicity from the EHRs in our admission, discharge, and transfer message. And you can imagine every possible writing of every race and ethnicity. And so we thought that's not going to be helpful to anybody looking at this data. So we did a little bit of natural language processing on top of it. And we were able to pretty effectively cross-reference that free text field to the CDC's race and ethnicity code set version 1 standard, which in HIE land, we always come back to the US CDI standard, which is part of that. So in terms of interoperability and reading from the same sheet of music, we were able to bring all of our various iterations of race and ethnicity data into that common standard layout, so that the CDC could use the data, which we then put into geocoding and heat mapping analyses, so that they could see specifically the areas in Maine that were getting hit hard by positive cases of COVID-19, and which racial and ethnic areas were maybe hit harder. And then they could inform their population health and care management plans from there.
That's great. Thanks, Chad. So we have about 10 minutes left, and then we're going to turn it back over to Charles and Norm to close out this year's NADO conference. So I think in the interest of time, David, do you want to talk quickly about patient care, and then I want to leave some time we have some questions in the chat, so we'll leave some time for that.
Sure, yeah. So I think the first example I've already mentioned our ED collaborative and their care coordinators using that map tool to identify and directly serve members who are high ED utilizers. That program is effective at reducing ED visits. So that's one example. Another example that I alluded to is looking at the vaccination data. As my team created reports and breakouts, we saw that MaineCare's Black or African American population was being vaccinated at lower rates than the MaineCare population in general. And we wanted to drill into that. So we started breaking race data out by county as well. We saw that there was one county in particular, Androscoggin County, that was especially affected by that disparity. And when we added another dimension to look at primary language, we saw that much of that population spoke Arabic. So we were able to kind of decipher through that breakdown process, looking at these different demographic features, that there is a large Somali population in that county in Maine, and we were able to pass that information along to leadership. They engaged with some community partners and discovered there was a lot of vaccine hesitancy within that community. But they were able to partner up with some community leaders and create some vaccine clinics and some materials from those community partners that could help address that vaccine hesitancy and increase vaccination rates within that community there.
Great, thanks, David. All right, we're gonna take some questions from the audience. The first one is from Jacob, and I think someone in the chat did address part of his question, but I think this is for you, Leanne, from Jacob Zelko. One of the most ambitious things on my mind is what can be done to better network between state APCDs across the US to create not only APCD partnerships, but networking of APCD information.
Agree. And I think the way that we've really approached this HSRI as an organization that does serve multiple state APCDs. Maine was our original, but we also now work in Colorado and Oregon and with a national association to create consistent data standards that can be shared across states, regardless if it's a state that we are, their data vendor or not, really promoting standards and so the sort of the call to action that I would have as it relates to this is twofold. One is state HIEs are also a huge wealth of information, and seeing more examples around partnerships. I think a couple of days ago, Delaware had some really good examples between APCD and HIE partnerships within that state, and I think we could both learn a lot, especially around data standards, because there's been requirements that HIEs have been held to that traditionally APCDs are just sort of getting up to speed through the FHIR HL7 standards. But I'm also of concerns around some of the practicality of implementation of some of those standards in the field, and would love to hear more. And this relates to the report that we're working on for the state legislature around the standardization of race and ethnicity. There are 900 choices for race and ethnicity on the CDC standard. And so how does that practically happen at the point of care, whether it's being self-reported or reported by a provider or payer, work its way through to a standard population health data system, whether that's the hospital encounter or an APCD? How do we practically make that information of high quality and available in ways that are reflective of that individual? And so I think there's some real challenges there. We've been able to sort of start digging into a little bit, but ultimately there's a single individual that's being tracked across all of these data systems, where there's got to be a better way to let that individual be exposed to how they are being identified and allow them to indicate their truth, right? I love the concept earlier in the session, or it may have even been last Friday, hierarchy of truth. The hierarchy of truth resides with that individual, and so how do we expose information to that individual in a way that they can confirm it, and then it's known, and we don't have to guess between all of our data systems. So that's sort of where I would like for us to learn together as a community how we can better create those identities in ways that are reflective of the data who we're collecting for.
Great, thanks, Leanne. Chad, I think there's a question here from Sinai. That's awesome. I think the question is, what's the example you gave of a gold standard?
Yeah.
How to use health data when it's needed?
Sure. So within HIE, a new standard that came out of ONC as of this last July, their version 2 of the United States Core Data for Interoperability, that's USCDI. That's the standard for interoperability that, as we do more with trying to get data across sectors for health or even in the hands of patients, that's the types of standards down to the data element level that HIEs and other infrastructure are held to. And so I think in my spiel about how we use race and ethnicity data at the HIE, I mentioned the CDC's Race and Ethnicity Code Set version 1. That's one of 2 examples. The second example is escaping me right now. That's within the USCDI's standard for race and ethnicity specifically.
Got it. Thanks, Chad. Well, we're pretty much at the end here. Sorry we didn't get to all the questions. If all of our contact information is out on this platform, so feel free to reach out to any of us individually if you have a specific question. I think that's okay, speaking on behalf of the panelists. I'd like to thank our panelists for a great discussion, and we hope you all heard some information that can assist you with your own initiatives to address health inequities. And thanks to Norm and Charles and the NATO team for putting together a great conference. And we'll turn it over to you, Norm and Charles. Thank you.
Great. Thank you, Jeff. And thank you, panelists. It's been wonderful. We just have a couple of items of business to wrap up. First one, as promised, I did the drawing at the top of the hour, and congratulations to our drawing winners. $50 in the top 20 category goes to Leila Yench from Chia, and then the overall winner of the $50 prize goes to Thea Mounts. And the $250 grand prize goes to Janice Bourgeau. Congratulations to all of you. I do want to take one last opportunity to thank all of our conference sponsors, and I hope that you have had a chance to look at their booths. They've provided some fabulous information there of things that they have done, and we really do appreciate their support. And then my last, item of business is we hope to see you all in Albuquerque. So if you haven't registered yet, please sign up. Let us know that you're coming so we can have a space for you, so we can plan ahead for your spot at the table. Thank you, everyone. It's been fabulous. Bye-bye.